With Dr. Eptihal. Are you ready?
Hold on just a second. Let me just start the recording 1 minute and then.
Okay. With Dr.
Hello, everyone. Welcome to our Zoom meeting. And today we'll have different topics. So when you are ready, Dr. Mahasin and your team, you can start. Thank you.
Assalamu alaikum wa rahmah. Good afternoon, Dr. Nadir. Good afternoon, everybody. Eptihal Nour. I will be presenting cancer screening today. Can you see my screen?
Yes.
Okay, so as I said, I'm Eptihal Nour. I will be presenting cancer screening with a TIL group. So let's start. Okay, cancer screening, understanding the guidelines and recommendations for early detection. When it is the learning objectives, we'll define the USPSTF and its mission. The goal is to articulate the role of this independent panel in establishing evidence-based preventive medicine standards for the US. So what's the USPSTF? The US Preventive Service Task Force is a scientifically independent volunteer panel of national experts in disease prevention and evidence-based medicine. The task force works to improve the health of people nationwide by making evidence-based recommendations about clinical preventive services. We'll also evaluate the screening rationale. So what's the goal of the screening? We need to understand the benefit, like reduce mortality, prevention, and the potential harms. Example, overdiagnosis, false positive results of cancer screening. We'll also master the grading system. So we will be able to correctly interpret the USPSTF's letter grades. The grade is A, B, C, D, I to determine the appropriate clinical actions. Example, when to offer, selectively offer, or discourage. We'll learn about all these gradings in the next slide. We also will be able to apply core cancer recommendations. So here we could accurately recall and apply current USPSTF guidelines like with age, method, frequency for the 5 primary cancers: colorectal cancer, breast cancer, cervical cancer, lung cancer, and prostate cancer. So what the core benefits of screening? The why. The goal of cancer screening is to reduce mortality and improve prognosis. We'll learn how. So the mortality reduction proven to decrease cancer-specific death rates. For example, breast, colorectal, or lung. And with cancer screening, we could detect cancers early, identify cancer at stage 0, 1, or 2, when treatment similar. So if you diagnose cancer early, you're not gonna need like invasive surgery. You also will not, the patient will not gonna use like invasive like chemotherapy or radiation, and it's more curative when you treat the cancer on like in early stages. There's other benefit of cancer screening is the power of prevention, the secondary prevention. We have 2 examples here, the colorectal and cervical cancers. Screening can detect and remove precancerous lesions, such as adenomatous polyps and cervical intraepithelial neoplasia, the CIN. So you detect it early before it transforms to cancer. We do surgery and we protect the patient from developing cancer. And the last benefit is the public health impact. Focuses healthcare resources on interventions with the highest net benefit. and reduces the overall burden and cost of late-stage cancer treatment. So I added the key statistics for cancer incidence and death mortality rate. So for 2025, the estimated new cancer cases is 2,041,910. And the estimated cancer deaths, 618,120. But we need to note that the number of cancer survivors in the US is growing due to population aging and advancement in early detection and treatment, which improves survival rates. Okay. Sorry. So now we're going to talk about the understanding the USPSTF grades and evidence. The USPSTF grades indicate the strength of evidence and net benefit. So as we said, they have grades A, B, C, D, I, and we're going to talk about what that means and when it's recommended and the action required. So first, grade A, which means that if cancer screening is grade A, that means it's strongly recommended. Why? Because there is high certainty that net benefit is substantial. The action required from the insurance companies, that they're required to cover cancer screening grade A and B. So there is mandatory coverage for grade A cancer screening. The other one is grade B. Here it's recommended, but it's like less than grade A. And because the net benefit is moderate, so it's high/moderate certainty, that's the benefit is outweigh the harm. Here too, it's required by the insurance company to cover any grade B screening cancer screening test. Grade C selectively recommends, so it depends on case by case. Here they said that the net benefit is small. Individual decision making is key. So it's patient choice. Grade D recommends against. Here, no, you don't do any cancer screening with grade D. Why? Because here the harms outweigh benefits, or there is no net benefit. So we do not screen any cancer screening with grade D. The I for insufficient evidence. So evidence is lacking. But what we're gonna do, the clinician and patient, they're gonna talk together about the cons and pros, then they're gonna make like shared decision. Note, grades A and B services must be covered by US insurance without co-payments under the Affordable Care Act. Okay, now we're gonna go through the main or major cancers in US. So we'll start with colorectal cancer screening. They divide patients by age. So they start at age 45 to 49. Here, screening recommended, which is grade B. So there is like moderate benefit. And test options is like FIT, which stands for fecal immunochemical test, and stool DNA. FIT colonoscopy, stool DNA FIT, which is a combination between the two lab tests, and CTC stand for CT colonography, like a CT scan, and sigmoidoscopy. There is many options to choose from. The other age group is age 50 to 75. Here screening is recommended, but it's grade A. So age 50 to 75, the benefit is substantial. We're gonna use the same test options like FIT colonoscopy, stool DNA FIT, CTC, and sigmoidoscopy. The last age group is 76 to 85. Here selective screening, the recommendation. And grade C. We said grade C depends on case by case. So the physician should like discuss the cons and pros with the patient. Test options individualized decision based on health and prior screening. So if the patient has like abnormal test result in prior screenings, maybe he's gonna need a colonoscopy. So we're not gonna use like the stool test. What's the acceptable modalities for average risk patients? There is two categories. Either direct visualization, we use for that colonoscopy, and the screening be done every 10 years, or flexible sigmoidoscopy, just for the sigmoid, and that we need to do it every 5 years, or CT colonography, the same like sigmoidoscopy, every 5 years. Okay, the other categories is stool-based, as we said, FIT, which stands for fetal immunochemical test, or FIT DNA. It's called Cologuard every 1 to 3 years, and the FIT alone is every 1 year. So the key takeaway is that the USPSTF values multiple screening modalities. The most effective test is the one the patient completes. Some patients prefer the stool test, and like they're anxious about the colonoscopy or any invasive screening modality. Okay, now I'm gonna do quick check. So we have a patient has a family history of colorectal cancer, but is otherwise asymptomatic. So he has a family history of colon cancer, but the patient has no symptoms. Does the USPSTF algorithm shown here apply to them? The answer is no. These guidelines, as we said, apply to average risk patients. Family history is considered high risk factor, and this patient require earlier and more frequent screening. So there's a different guidelines for any patient with high risk factors. Often directly with colonoscopy, as we said, it depends on the prior screening. If you find any abnormal test, we're gonna need to do like more invasive modalities like colonoscopy, because we need to visualize what if there is progression or anything like that. The other question, why does the USPSTF recommend selective screening, which is grade C, for eggs 76 to 85? C, it depends on the patient, and he needs to be involved in the decision. They said even if the patient has never been screened, he's elderly, he's old, 76 and older, and he never have any screening. So here is grade C because there is decreased life expectancy and increased risk of complications from colonoscopy at older age outweigh the potential benefits. At this age, maybe he has like more comorbid conditions. His life expectancy is lower than like 10 years. So he's not gonna benefit. Even if you find a polyps or any lesion, he's not gonna benefit from doing the screening. Let's move to breast cancer screening. The same, there is 2 age groups. So the breast cancer screening starts at age 40 to 74. We do that pineal screening mammography with mammography. It's grade B. Pineal mean we do it every 2 years. So starting at age 40 to 74. Then the other age groups is age 75 plus. Here there is insufficient evidence that they're gonna benefit from the screening. That means grade I, and the decision is gonna be individualized. Maybe one patient has an abnormal test before, so we need to do it. If a patient has like multiple screening before and all the tests are normal, we're not gonna do the screening for any patient age 75 plus. We need to know that there is new update, grade B, about the breast cancer. So the recommended start age was recently lowered from 50 to 40, 40 or old for all women. They used to start the screening at age 50. Now, because the incidence increased, they lowered it to age 40. the interval USPSTF specifically recommends biennial, which means every 2 years screening. There's like different agencies with different guidelines, but I wanted to focus just on the USPSTF, and they do it every year for breast cancer. Like the American Cancer Association, I think they do it every year. Okay, we have another quick check here. In what clinical scenario should screening mammography be stopped immediately in a 55-year-old patient? So she's young, still 55. We said we're gonna do it until 74. Why are we gonna stop it? What the reason could be? So as we said, every patient, every screening, we need to see if the benefit outweigh the harm or not. So if we stop it at 55, that means the patient life expectancy is less than 10 years. Maybe the patient, she has like a comorbidities like advanced heart failure or metastatic disease. So she's not gonna live long enough. That's why we're gonna stop the breast cancer screening. Okay, next we're gonna do cervical and lung cancer screening. Cervical cancer screening starts at age 21 to 65, and all these age groups is grade A. So as we said, the benefit is substantial, but they divide them to two age group because the frequency and the modalities differ between these two age groups. So age 21 to 29, we just do cytology, that's pap smear alone, and the frequency we do it like every 3 years. After that, age 30 to 65, they have more options. We could do the cytology alone, like the pap smear, like the younger age group, or we could do co-testing. Co-testing is the cytology plus high-risk HPV test, or we do primary high-risk HPV test alone. So either colonoscopy, either cytology alone, HPV test alone, or combination between both. If you do HPV test, you give them more like time, so we do that every 5 years. But the cytology, they need to do it more frequent, so it's like every 3 years, like the same younger age group. For breast cancer, there's grade D. Grade D, we said don't do the screening. So we're gonna learn about them. So women younger than age 21, we never do screening. And the other group is women older than 65, but not any woman with age 65. We're gonna stop the screening. Like there's specific requirements. So women who had adequate negative prior screening, so she did multiple pap smear, she had 3 consecutive negative cytology, or 2 negative core tests in the past 10 years. At this case, we're gonna stop. And no history of CIN2+ or cancer. No need to do more screening. And the last group is women who had a hysterectomy with removal of the cervix. So that means complete hysterectomy, total hysterectomy, with removal of the cervix, and do not have a history of high-grade precancerous lesions. So no history of cervical intraepithelial neoplasia, grades 2 or 3, or cervical cancer. Let's switch to lung cancer screening, which is grade B. So lung cancer screening, we do it for patients age 50 to 80, but there's specific requirement with 20 back year or more history. So not every smoker we're gonna do the lung cancer screening. There's a specific number of like back year history, and currently smoke or quit within the past 15 years. So either currently smoker or he quit recently. We need 15 years to decrease the risk of lung cancer. So test and interval, we do annual screening with low dose CT scan. Age 50 to 80 annually with low dose CT scan. So what the discontinuation criteria? Screening should be discontinued once a person has not smoked for 15 years or develops a health problem, as we said before, with every screening that substantially limits life expectancy or the ability or willingness to have curative lung cancer, lung surgery. So the patient is friable, he can't have surgery, he can't do biopsy. We start doing the lung screening, cancer screening, or he stopped with the smoking for more than 15 years or 15 years or more. Okay, now is I'm gonna take a break, engagement break. Case study, we're gonna assess screening eligibility. We have a question. You can unmute and answer the question. I don't want you to sleep. A 70-year-old patient quit smoking 18 years ago. He smoked 2 bags per day for 25 years. Is he eligible for annual low-dose CT scan screening? Why or why not? You can unmute and answer. I'll give you a few to think.
This
He's not
patient is not eligible.
Okay, he's not eligible. Why?
Since he's just smoked 2 packs, he's supposed to smoke 20 packs to be eligible, and he's also and he quit more than 15 years ago.
Okay. Any other input? Okay, so you're right about that. He quit smoking more than 15 years ago, but I know that's confusing, but the back year history is, you don't just look at the 2 bags. That means, okay, they require 20 bags. No, you I'll show you the answer. You count the back year history with the number of bags per day times how many years been taking that bags. So he took 2 bags per day, but for 25 years. If you multiply 2 by 25, that means he takes 50 bags per year, not just 20. So it's like that's more than double. It's not like easy forward. You just read it. You have to do some math to know the back year history. But you're right about the first part, that he quit smoking more than 15 years ago. That means his risk of lung cancer is decreased, so no need to do more screening. So no, although the patient met the age and back year criteria, so that 2 back per day times 25 equals 50 back years, they quit more than 15 years ago, which is the cutoff for eligibility. Thank you. So let's start this. We're gonna finish by talking about the prostate cancer screening. The same, they divide the patients by age. So start at age 55 to 69. Prostate cancer screening is grade C. So it's like, as we said, C, that means shared decision making for, we do the prostate cancer screening with PSA, which stands for prostate specific antigen based screening. What the risk-benefit balance? There is a small potential benefit, that's why it's grade C. That means the benefit is not like moderate or substantial, that's we need to do it to every patient. There is small potential benefit of mortality reduction, but high risk of overdiagnosis and overtreatment. It's like 50-50. That's why, okay, you give all the information to the patient, then you make the decision together. About the patients age 70 plus, recommends against. So against PSA-based screening, that's grade D. Here, harms, example from treatment-related erectile dysfunction, if you find like cancer or incontinence, all this harm are overweight the benefit in this population. The key discussion here, the grade C recommendation requires the provider, again, they're going to keep saying it, requires the provider to engage the patient in a thorough discussion about the risk. You have to tell him about the percentage of false positives, biopsy complications, overdiagnosis versus the modest benefit. Let's do, again, quick checks. So if a screening test receive a grade D recommendation, are insurance companies in the US required to cover the test under the Affordable Care Act? The answer is no. We said just A and B because the benefit is outweigh the harm. So no, only grade A and B grade services receive mandatory coverage under the Affordable Care Act. Grade D service are recommended against screening. C 50-50, D is no. We have another question. What is the most significant harm the USPSTF weighs when recommending annual low-dose CT scan despite its proven mortality benefit? So the moderate rate of false positives leads to anxiety, unnecessary follow-up imaging, and occasionally invasive procedures like biopsy. If you see anything that you suspect that's the cancer, you're gonna need more invasive procedure after that. That's why there is like specific requirements. Only high risk patients. You know, we notice that not all the smokers we do the lung cancer screening because all of these harms. Understanding the nuance of USPSTF recommendations is crucial for providing effective patient care and promoting preventive health. Okay, this is evidence-first approach. The USPSTF is evidence-first, so that means its primary goal is to ensure that the benefits of screening outweigh the harms. As we said, the harms like overdiagnosis, anxiety it could cause, complications from the screening for the average risk population, not all patients. If the patient is high risk, there is family history, you find any suspected lesion in the prior screening, that's a different story. Okay, we need to master the grades. A and B grades ensure coverage, as we said. C requires shared decision making. You have to involve the patient, give him all the information. And grade D is recommendation against screening. Here the harm is more, or the benefit is way less to recommend doing the screening. What the evolving recommendations? So there's shift. They do a lot of research. They keep updating the screening. I remember that we were studying for step 2 and okay, we keep memorizing all this screening and timing and they change it. So you need to always check the USPSTF guidelines on their website. The latest shift they have is moving toward earlier screening for high burden cancers like breast and colorectal cancer. So breast, as we said, the breast cancer, they used to do it at age 50, they lower it to age 40. Same with colorectal cancer, they lower it from 50 to 45. Okay, guys, thank you so much. We appreciate your time and attention to these crucial guidelines. Your dedication to evidence-based screening practice is vital for improving patient outcomes. Thank you so much for listening.
So Dr. Nader, do you have any additional information?
Hello, everyone. Thank you for a great presentation. This is, I think, a very important area everyone should know about, but thank you so much.
Thank you,
Nothing to
doctor. Thank you so much.
Thank you, Dr. Eptihal.
Thank you, Dr. Mahasin. You're welcome.
Okay, we can move to the next presentation with Dr. Mudathir and Dr. Asna.
Okay. Good
Okay.
evening, everybody. I'm going to share my screen. Okay. Do you see it? Hello?
Yes.
Am I audible?
Yes.
Yes, Dr. Mudathir.
Okay. So good evening, Dr. Nader, and good evening, everybody. I am Dr. Mudathir Omer, and I'm going to present a topic about effective communication with patients and interdisciplinary teams. I'm just going to start with the first part of this topic, which is effective communication with patients. So the key messages of this presentation is that communication is integral to all aspects of patient care. Communication also is a core clinical skill that can be developed and improved with practice and experience. Effective communication has a significant positive influence on patient experience and satisfaction, and poor communication contributes to medical errors, misdiagnosis, and inappropriate treatment. So now, why effective doctor-patient communication is important? Number one is to build the trust. Patients are more likely to share accurate, complete information when they feel heard and respected. Also, to improve diagnosis and treatment, as clear communication helps doctors gather better histories and understand symptoms more accurately. Also, to enhance treatment adherence, patients who understand their condition and treatment plan are more likely to follow medication schedules, lifestyle changes, and follow-up visits. Also, supporting shared decision-making, involving patients in decisions lead to respect their autonomy, also lead to more personalized care and greater satisfaction. Number five, reducing anxiety and fear, as empathetic explanation reduces stress, especially in serious conditions. Also, to prevent medical errors, misunderstanding about dosage, procedures, follow-up can be avoided with clear confirmatory communication. Also, to improve health outcomes, research shows patients with better communication experiences have faster recovery, better pain control, and improve overall health. Also, in terms of gathering sensitive information, effective communication can help professionals navigate through these sensitive situations and keep the integrity and well-being of the patient intact. Of course, also there are some benefits for doctors, like reducing conflicts and complaints and enhancing professional fulfillment. Now we're going to discuss principles of effective doctor-patient communication. So these some of the most important principles. We have clarity by using simple jargon-free language that the patient can understand. Also by showing empathy and compassion and acknowledging the patient's feelings. Also through active listening, giving full attention to the patient and using verbal and non-verbal communication. Also through respect, by respecting patient beliefs, culture, and preferences. And also through honesty and transparency, through providing accurate information regarding diagnosis, prognosis, and treatment. Also, regarding confidentiality, building trust by ensuring privacy and ethical handling of information. Also, and the most important thing is the patient-centeredness, which involve patients in decision about their care in all levels of decision-making. So what is patient-centered communication? Patient-centered communication is a style of doctor-patient interaction that focuses on the patient as a whole person, not just their disease. So it emphasizes respect, empathy, and shared decision-making while taking into account the patient preferences, values, cultures, and life circumstances. So these are the core features of patient-centered communication. We have understanding the patient perspective through exploring the patient ideas, concerns, expectations, and feelings. Also holistic focus, looking beyond the illness to include psychological, social, cultural, and lifestyle factors. Also shared decision-making, as we said previously, involving the patient actively in choosing investigations and treatment plans. Also through showing empathy and respect, validating emotions, showing compassion, and respecting autonomy. Also, a clear two-way information exchange through using simple language, checking understanding, and encouraging questions. Also building a therapeutic relationship by creating trust and openness and continuity of care. So these are the most important core features of patient-centered communication. And now we're going to talk about types of communication in healthcare as general. We have verbal communication, which includes speaking to the patient through in person or via video calls or telephones or whatever. Also using nonverbal communication through using gesture and body language. Also we have written communication like prescription, emails, or referral letters. Also, we have communication called formal communication, which include conveying information to patients using photos, charts, and graphs. We're going to discuss this type of communication in details. So now we have verbal communication. So these are most important tips that we have to follow as doctors in verbal communication. We have to use a plain language through avoiding complex jargon and technical terms, instead use simple familiar words. Also being patient and attentive, allow patient to complete their thoughts and ask questions without interruption. Also confirming understanding, ask the patient to summarize what he understood to verify comprehension. Also through asking open-ended questions, use questions like what question, when you are talking to your patient, you can say, what questions do you have, to encourage your patient to speak more freely. Also engaging and empathizing, show genuine interest in the patient perspective and use body language, as we said above, and that conveys empathy and care. And also involving the patient, makes the patient an active participant in decision making for their care and treatment plans. So there are some strategies for doctors regarding discussing complex medical terms with their patients. As we all know, complex medical terms or medical jargons and, and concepts can create a barrier between doctor and their patients. So we can use these strategies to overcome that barrier. The first strategy, starting with the big picture. When speaking with patients, it is helpful to frame what you are saying in a way that drives major points home. Patient may be focused on things like convenience, while you are focusing on avoiding complication. For example, if your patient condition is expected to worsen if they don't begin medical therapy, prioritizing that plan of action is of primary importance. Your patient, on the other hand, may be concerned about another issue. Take the time to address that concern, but be sure to re-emphasize the urgency of getting that physical therapy. The second strategy, using patient-friendly terminology, using clear language and avoiding technical jargons and terms will help your patient understand complex medical information. A study published in Health Literacy Research and Practice found that sometimes patients neither understand medical terminology nor recognize the gaps in their comprehension. At the same time, take care to avoid oversimplifying your explanation, like using this sentence, which is disease-fighting army, to describe an immune condition when speaking to an adult, even if some children would appreciate this type of explanation. Now we have some medical terms. When discussing with our patient, we have to avoid these terms, and instead we can say, or we can use their opposite lay terms. For example, we can avoid saying the word abdomen. Instead, we can say belly or stomach. Also, bradycardia, we can avoid that term, and instead we can say slow heartbeats. Also, some words like influenza and lethargy and myocardial infarction, all these medical terms, we can avoid using these medical terms, and instead we can say or use their opposite lay terms in order for our patient to be easy for our patient to understand these terms. The third strategy is making the most of supplementary materials. Consider proactively selected resources that explain the conditions and provide a short list of reliable sources, or direct your patient to your hospital website. Other supplementary materials like printed literature and visual aids may be useful in communicating complex information. For example, a recent survey published in Medical Decision Making revealed that most primary care physicians prefer to use visual representations of hemoglobin A1C test results when sharing these results with their patients. So you have to make the most of your supplementary materials. The fourth strategy is balancing family support. As we all know that family members can be helpful when complex medical issues are being discussed. They may provide support, reassurance, encouragement, remembering important steps in a care plan. But unless the family member have a power of attorney, it is important to take a consent from your patient regarding the presence of other people, and to follow your patient's wishes above any other concern. The fifth strategy is to work around language barrier. A translator or interpreter can be of value when discussing simple, complex medical terms, but it's crucial to use a professional translator who understands medical issues. A study published in the Advanced Journal of Emergency Medicine showed that translators who are not medically knowledgeable, including family members, are prone to conveying inaccurate information. So if you need to use a translator or interpreter, it is better to use a translator that is capable of understanding medical terms and medical issues. The sixth and last strategy is to check to see that everything is clear, because sometimes a patient may be in denial about their illness, which can cause them to hear something that doesn't match what you have said. So you have to assure that they understood that well. Okay. Now we're going to talk about the second type of communication, which is nonverbal communication. Nonverbal communication norms refer to the culturally specific unspoken rules for interpreting behaviors. These norms vary significantly across cultures. For instance, maintaining eye contact is a sign of confidence in Western cultures, but may be seen as disrespectful in many Asian or Arab cultures. So these are the key aspects of nonverbal communications. We'll start with warmly greeting the patient. Begin by introducing yourself and stating your role. Also, keeping eye contact is very important, and it's going to show attention and engagement. Also, a facial expression can tell a lot. A warm expression and a smile can make a patient feel at ease. Also, showing empathy, acknowledge the patient feelings and perspective to build trust. And also body language and posture, like an open relaxed posture with uncrossed arms and legs, convey comfort and confidence, whereas crossed arms can indicate defensiveness or unwilling to listen. Also, leaning forward, sit when possible, and lean forward slightly to signal engagement and interest with your patient. Also, the gesture, nodding your head shows you are listening and engaged. Also, maintaining a soft and gentle tone. A soft tone of voice helps patients feel more comfortable and less intimidated. Also, maintaining interpersonal distance also show respect to your patient. So these are some of the important skills that we need as doctors in daily practice. We can use open-ended questions, ask broad questions to encourage patients to share their perspectives. Also, empathetic statement, acknowledge the name and acknowledge and name your patient emotions. For example, you can say, I can see that you are feeling upset and frustrated. Also, validation, show understanding and support for the patient emotional responses to their illness. And always seeking consent. Obtain consent before performing actions or sharing information to empower your patient. Also, follow up, check on the patient's progress and address ongoing concerns to provide continuous support. Now, what if doctor-patient communication fails? A failure of communication can lead to misdiagnosis, improper treatment, and negative patient outcomes, emphasizing the need for better communication skills education for doctors and active participation for patients. So now we are going to navigate through the causes of communication failure. We have physician factors. We have physician factors. Also, we have patient factors and systematic factors. We'll start with physician factors. We have high workload, a limited time with patients, making it difficult to deliver satisfactory communication and care. Also, lack of training can lead to inadequate performance in this area. Also, misunderstanding the importance of communication. Some physicians may not fully grasp the critical role communication plays in improving the physician-patient relationship and patient healthcare and patient health outcomes. So these factors regarding physicians. Also, we have factors regarding patients themselves, like low medical literacy, patients' limited understanding of medical terminology can create a barrier, as we said, can create a barrier to effective communication. Also, difficulty explaining concerns. Some patients may struggle to articulate their symptoms accurately, especially when facing mental distress. So these factors regarding patients. Also, there may be systemic factors like language barrier, as we said, or a weak healthcare system. A structural weakness in the healthcare system can contribute to communication failures. And now we're going to talk about the consequences of this communication failure. Of course, we have there's going to be medical errors. Poor communication can result in misdiagnosis or suboptimal treatment. Also, negative patient outcomes. Communication problems are directly linked to poor health outcomes for patients. Now we're going to talk about how to improve communication. First thing for physicians, of course, training, incorporating mandatory communication skills training into all levels of medical education and continuing medical education. Also through empathy and awareness, developing strong interpersonal and ethical awareness, and cultivate empathetic reactions. Also through time management, managing limited consultation times more effectively. Regarding patients, there must be a preparation. For example, a patient can write a list of concerns or questions before visiting the doctor. Also, active participation. The patient must participate actively with his patient through asking clarifying questions to ensure his understanding. Also, we can do a systemic change, like support for training through implementation of new effective communication teaching methods and media. Okay, that's it. And my colleague is going to continue the second part of this topic. So, thank you. I'm going to stop sharing.
Assalamu alaikum. Good afternoon. Can you hear and see my screen, please?
Yes, Dr. Asna.
Okay. So my name is Asna Shireen, and I'm be continuing with the second part of the presentation. Thank you so much, Dr. Mudathir, for the amazing presentation. My topic is effective communication with the interdisciplinary teams. All right, so what is interdisciplinary communication in health? So it basically means clear, respectful, timely, and structured information exchange among diverse healthcare professionals. It promotes patient safety, quality care, and staff satisfaction through seamless collaboration. It overcomes barriers that stem from different professional backgrounds, languages, and institutional hierarchies. And it cultivates a teamwork culture supported by standardized communication tools and technology. So what is the importance of effective communication? It boosts patient safety by minimizing errors and improving care coordination. It enables holistic care through diverse input from doctors, nurses, pharmacists, therapists, and social workers. It improves efficiency by eliminating duplicated efforts and conflicting care plans. It enhances staff satisfaction by fostering collaboration and reducing burnout. It drives better patient outcomes through comprehensive, personalized treatment plans. So the key elements of effective team collaboration is clarity, using precise language and avoiding jargon to ensure understanding, active listening, that is value and respect the team input to foster collaboration, standardized tools, using them such as SPAR for structured information exchange, mutual respect, recognize diverse expertise to build trust across teams, and timeliness, communicate promptly to prevent delays in care and decision making. So what are the 4 strategic pillars which enhances this collaboration and improves the patient outcomes? Firstly, is to standardize communication protocols. Adopt structures like SPAR and closed-loop communication to ensure clarity and reduce errors. Encourage direct and frequent interaction. Facilitate regular team meetings, interdisciplinary rounds, and cultivate psychological safety to promote open dialogue. Third is leverage advanced technology. That is, integrate EHR systems, secure messaging, and telemedicine platforms to streamline communication and data sharing. And invest in interprofessional education. Implement communication training, shadowing experiences, and simulation exercises to build teamwork skills. So what are the effective handoff communication in healthcare? It is to basically transfer essential patient information, responsibility, and accountability between providers or teams. It occurs during shift changes, unit transfers, and care transition to maintain seamless care. It ensures continuity of care, patient safety, and shared understanding among healthcare teams. And it prevents critical information loss and significantly reduces the risk of medical errors. So some of these standardized tools that are frequently used are the SPAR, the IPAS, and the SOAP. So the SPAR is primarily used for structured verbal handoff. And the key benefit is that it is a concise, clear communication framework where S stands for situation, B stands for background, A stands for assessment, and R stands for recommendation. The IPAS, it is primarily a validated handoff tool, and it improves accuracy and reduces errors, where I stands for illness severity, P stands for patient summary, A stands for action list, S for situation awareness, S for synthesis by the receiver. SOAP is basically mainly used for documentation, and it facilitates organized clinical notes for continuity. S stands for subjective, O for objective, A for assessment, P for plan. And of course, using face-to-face communication with readback verification, it enhances the clarity and reduces errors, and engage patient and families in the communication process when appropriate to support safety and understanding. So this is an example of a handoff between an intern to intern using the IPASS method. So report the patient status. First, we're going to start with the I, that is the illness severity. So if I'm giving the handoff, I'm going to report the patient status as stable, indicating the current condition. And the next step is I'm going to give the patient summary. I'm going to summarize the key details. For example, Mr. Ahmed, 65, admitted with heart failure on IV diuretics. Third thing that I'm going to give in the handover is the action list. That is to specify the tasks. Monitor urine output and recheck potassium at 10 a.m. S is going to be situational awareness, highlight the risks. That is risk of arrhythmia if the potassium drops further. Hence, rechecking the potassium at 10 a.m. is important. And lastly is the synthesis. We are going to ask the person whom we are going to give the handover to repeat everything that I've said to ensure that they understood the task. So what are the key challenges that hinder collaboration? Some of them that were covered by Dr. Mudathir. I'm going to go briefly over them. Hierarchical culture restricting open and honest dialogue, differences in the professional jargon causing frequent misunderstandings, time pressures, heavy workloads, absence of standardized protocols, and inefficient technology use and fragmented EHR. Mastering SPAR for the clear clinical communication. So on a side note, I remember that I had once taken up a course, which was vital anesthesia simulation training, which costed over $60. And in that course, I had learned about SPAR. So when I saw this topic come up in the group, I was like, I have to take this, because if there's one thing that I want everyone over here to take from my presentation is the use of SPAR for handovers. It is so simple and so convenient. And as juniors, nobody tells us. So I think this is a good takeaway from my presentation. So I'm going to repeat what S stands for. S is for situation. Deliver a concise, focused description of the current problem or issues. Give the background of the patient. Provide relevant context or patient history to support understanding. A is assessment. Share the clinical analysis and considerations based on current observations. And R are the recommendations. Specify the requested action or next steps to address the situation. So this is an example of an SPAR. The situation is, this is Sister Emily from ICU. I'm calling about Mr. Smith in bed 5. He's short of breath. Oxygen saturation dropped to 85%. So this is a nurse who is giving a handoff to a doctor. The background will be that he was admitted yesterday with pneumonia and is on IV antibiotics. He has a history of COPD. A is assessment. His respiratory rate is now 32. He's using accessory muscles and his blood pressure has dropped to 90/60. R is, I think he may be deteriorating. Could you review him urgently? And I can also recommend use of high flow nasal oxygen. So this is a good way to remember what key information we are supposed to give to our seniors in conditions of emergencies. So what are the key benefits of doing this? Is it reduces errors during handoff emergencies or contacting physicians. It provides a uniform communication format across all healthcare staff. It enhances patient safety and commonly used in nurse to physician calls. But of course, it can be used between juniors and seniors in shift handovers, patient transfers, emergencies, and interdisciplinary communications. Thank you so much.
Thank you, Dr. Mudathir. Thank you, Dr. Saida.
Thank you both for great presentation as well. And it's very important to focus on this. And if you can use the same tool in your practice, and hopefully when you match and in the future. Thank you.
So the next topic, I will be the presenter. Is it my screen appear to everyone?
Yes.
Okay. So today I will talking about how to create and share online survey for research or quality improvement project. I will compare three common tools: Google Form, SurveyMonkey, and Qualtrics. Okay, and highlighting their benefits and their limitation. So the basic workflow is similar across the all platform. First, we design the survey by defining the goals and choosing appropriate question style. Some tools also allow advanced logic branching. Next, the survey usually via link or email or QR code, and we can control who has access. Finally, we collect and analyze responses. Most platforms allow real-time tracking and export of data for further analysis. So let's start by the first one, Google Forms. The Google Forms is free and very easy to use. It's integrated directly with Google Sheets, which makes data analysis simple. There is no limit. There is no limit on the response, and the sharing is straightforward. However, the downside is that the customizations is limited. The design looks basic. The questions type are not as the question type are not as drives, and analytic are minimal. When we talk about the data security is also less compared to more advanced platform. So this is let's talk. Let's say like the limitations of Google Sheets, Google Form. Sorry. Okay. The next type is SurveyMonkey. SurveyMonkey is widely used survey tools that offer a user-friendly interface and a good variety of questions type. It has built-in analytic and with paid plans. You can use skip logic and branching. The limitations are mostly with the free version. The number of questions and the response is escaped. Advanced features require subscriptions, and data export options are restricted unless you upgrade. So the last type is Qualtrics. Qualtrics is very powerful platform, especially for academic and for the academic research. It supports highly customizable survey, which complex logic, strong analytic, and robust security feature that met standards like HIPAA and GDPR. It's also integrated well with statistical software. Okay. when we talk about the limitations of the Qualtrics, okay, we have Qualtrics is often only available through institutionals, and it has a steeper learning curve. For a smaller and a simple project, it may be more tool than you need. So this is the compare between the three types. So when we summarize the three types of okay, Google Form is best for simple because it's simple, free, and quick survey. When we talk about the SurveyMonkey, offer a good balance, and especially if you need more professional feature. Qualtrics is the top choice for advanced research project. So the choice depends on your project complexity, the budget, and the data security need. So thank you, guys.
Thank you so much, Dr. Mahasin. Any questions?
Welcome, Dr. Nader.
Great presentation.
Thank you. We can move to the last presentation for today with Dr. Mohammed Makkawi.
Yes.
Hello, everyone. Can you hear me?
Yes, Dr. Mohammed.
Okay, so I can start my presentation. Okay. First, hello, everyone. My name is Dr. Mohammed Makkawi. I'll be talking about using the program Zotero and how to use it in referencing and how to use it to store your library, to make your own library of research. So first thing, we just download the program. It's available. You can just Google it. Download Zotero. You'll find it in their website. You'll find two options. One is downloading the program itself. So you press here, download, to download the program and install it as usual. It's available both in Windows and Mac as well. And then we have a connector, which serves as an extension. You can also install it. It's compatible with most of the commonly used browsers. So why am I recommending it to use both? Because there are two main ways of saving your papers, which will involve having them both. So it's better to have them both with you. So let's, for example, before that, let's say that you're doing you want to write an essay regarding if there is any association between MMR vaccine and autism. So you check in Google Scholar and find various researches there. Okay. So you want to have this, you read this study and you're interested in writing from it and using it as your reference. So there are two main ways of saving this. The first method, let's say that you already downloaded the program and installed it. So once you install it, this is how it will show. I've already did a lot of research work, so I have many researches saved. So no, when you start, you will have an option here, My Library. You can make your own folders, a collection, which here they call it collection. And for example, I made here about cardiovascular disease, climate change, diabetes, healthy cities. So you can categorize your researches. You can also do subcategory as well. You can also make another collection within the same folder. Okay, let's do this. For example, here we have healthy cities, and then we made another one, healthy city Doha, which is a sub folder. Okay, so you need to have the program running. Okay, then as the program is running in the background, then you open to the research that you are interested in adding. Make sure that you have access to the paper, the PDF file. Make sure that you have access to it before you use it. Otherwise, you will download the information, but you will not be able to download the PDF file. So make sure that you have access to it first. This paper here is free, so everybody has access to it. So one of the methods is by using something that we call a DOI, which is an identifier. Most papers, they usually have it. You can check it in artificial. Okay, this one doesn't. Maybe this one has. No. Okay, let me just show you one that has DOI just as an example. Okay. So usually papers will have an identifier which is known as DOI. You can see that will show you as a link. All right. This paper, I don't have access to this paper. So you can copy it, copy the link, and then go to the program, Zotero. Okay. You will find this one icon. Okay. If you click on it, it will show you a place where you can fill it. So you can paste it here and then press enter. Then automatically the program will download for you the paper. Because I don't have access to the paper, I don't have the PDF file. But you can see all of its information here. The journal type, or the authors, the publication, the pages. Like every information about the paper will be there. But in order to have, but if you have access to the paper, you'll be even able to open the paper itself. Okay. So this is one way of getting your paper, of saving your paper, adding files. Another way, which is an even more direct way. Hold on. Let's say you have this paper. Let's say you don't find the DOI, just like earlier we couldn't find the DOI. It's over here. This is the DOI. So you can just copy this, just like I've showed you previously, and you will be able to download the paper. Let's say that you don't find the DOI. Once you download this extensor, this connector, you will be able to find it here as an extension. So you can just click here, run extension, and it will automatically save the paper to you to the program. Let me try this paper. Okay, we just wait for a few seconds and it will download for you this paper. Right? So then if you want to open the paper, you can just simply double click them. If you have access to it, you can just double click and automatically you can see the paper and you can review it. one of great advantage is that once you download, save something in your Zotero, it will gonna be with you forever. So whenever in the future you want to go back to it, you can always do so. Another thing you can do is you can also connect the Zotero to your Google account, so that when you transfer to another device, you can just log in with your credentials and you can continue using your library as it is. Okay, so this is the first part. Okay, just hold on. Yeah. So you have the program should be running in the background. Now, how to use this program? How to use it when you're trying to reference in your essay? Okay. Let's say that you have this short paragraph. Over here, you wrote some stuff about the reports about MMR vaccine. So you took this information, for example, from this paper here. You took it from this paper, okay? And you wish to reference this paper to the essay that you have been writing. So you can find here, I'm using LibreOffice. This also works with Microsoft as well. You will if you install the program, you will find these additional extensions. Here you can find add edit citation and add edit bibliography. Bibliography is your list of references. So if you just want to write the citation, you can just click here, add edit citation here. Just wait for a while. Okay. Then this program, the Zotero will show up with this highlight. So it depends on what type of referencing method that you wish. I'm mainly using the Harvard style. So we'll choose this choice, Coventry University, Harvard. Once you click OK, once you click OK, the citation will show up. All right. Then in the Zotero, this small section will show. Just press double click on it. Let me try again. Not showing very well. So, but all you have to do is just press here. Whenever the place where you want to write the citation, just press add edit citation to show you the small window. Double click it and automatically it will fill it. It will fill here for you. Okay. It's now able to show. So here automatically the reference has been filled here. Furqan and Sinclair 2021. In the Harvard style, it will show you the name of the authors and the year of which it was published. Okay, so let's say that you have done, let's say you have already references, and then now you wish to write your put your bibliography. Just press this one, add edit bibliography. Paper here. Just press add edit bibliography here. We again show you the same window, and automatically the bibliography will be shown here. The complete detail of the study city planning for neighborhood and city scale green neighbor system in Qatar, case of MIA part. So it will do your heavy lifting for you and references and save your papers in the library. Okay. If you have any questions, sorry that I had some issues with my sharing. It was not showing everything. Well, if there is any questions, you can ask in the chat. Okay. Thank you very much.
Thank you, Dr. Mohammed.
Thank you so much. This is also excellent presentation, and it's a very useful tool. There are a couple of other tools that can be used as well. Some of them are free, some of them you pay for them. But the same idea, the tool, you can use it to cite or list your references in a way that can be used. And one of the important thing is when you want to submit a manuscript for a journal, sometimes they will ask you about changing the reference citation description from one format to another, depend on what journal that you apply to or submit your manuscript. So using these tools will help you tremendously when, let's say, you apply to or you submit your manuscript to a journal, and if you get a rejection, you want to submit it to a different one. If the format is different for the references, then you will have a lot of time just tweaking and changing. But if you have this tool or similar tools, it's one click that you use and it will format the citation for you easily. Thank you so much, Dr. Muhammad. This is a very good presentation. Any questions, or anyone wants to share their experience, like if you use Zotero or did you use any other citation tool? In the past, I used both Zotero and I used EndNote. It's a different one. It's paid, and but the idea is similar between both of them.
Yes, Dr. Nader, as confirmation to this, I used Zotero before Mendeley and EndNote. EndNote is really good, but the only downside of that is paid. But Zotero is really good and very simple. Even if it's your first time to do a research paper, it will be very easily and self-explanatory.
I agree with you. Thank you for sharing.
Okay.
Anyone else?
Hi, everyone.
Yeah.
I only used Mendeley, and its learning curve is quite easy. I learned it over 1 hour, and it was good. I use it in different papers, and it's easy to use and provide everything I needed.
Sounds good. So maybe in the future you're gonna teach us or do a demonstration of how to use it, if you don't mind.
Of course, I don't mind.
Thank you.
I personally have been using Zotero for almost a year. I'm doing a master's in public health. So for almost a year, I've been using Zotero. I never faced any issue with citations or saving. So it's a very convenient program. I recommend it for anybody to use it. Just be sure that you have access to the paper so that you can have it whenever you wish to go back to it again.
Agree.
I can add to that Zotero is implemented in Google Work platforms. So, because the Microsoft is often also paid, especially in the iOS system. So this is my way around to pay a Microsoft payment. It's really good at this point.
Well, if you don't have Microsoft, you can still. I'm using LibreOffice. It's free. You can do almost everything like Word, Excel, PowerPoint. The same thing, and it's compatible with Zotero. So you can, if you're not able to have Microsoft, you can also use it as well.
Can you send us the link, please, Doctor? I will be thankful for that.
Yeah, I can show you. I can share the link here in the comments.
I appreciate it.
Okay, and we can move on to the updates section. Any updates as far as projects and new ideas, questions, what you are doing, guys? Please share your experience or updates.
All right. Assalamu alaikum, Dr. Nadir. How are you doing?
Alaikum assalam wa rahmah. How are you?
I'm good, thank you. So, Dr. Nadir, I wanted to speak about our poster, our abstract that got accepted at HFSA last weekend. And before that, I just wanted to add that at the end of my presentation, all thanks to Dr. Mudathir, he helped me collect all the data for my presentation as I was short of time. Okay, moving on to the HFSA. Dr. Nadir, can I share my screen?
Yes, please.
Can you see my screen, Dr. Nadir?
Yes.
All right. So this is the poster that got approved. We have written an entire article. Firstly, thanks to my entire team members, Roya, Reem, Mason, Mad, Lipi. Without them, this is part of Forest Green project. And without their help and support, we wouldn't be able to complete this. And it is such an interesting topic. Our topic is gut microbiome metabolites that they predict mortality and hospitalization in heart failure. So when we did a rough search on this topic, we found that majority of the articles, they only covered some of the metabolites, or they only spoke about, for example, trimethyl lysine, or particularly about phenylacetylglutamine. The focus was mainly on these two metabolites, but when we went through all the relevant literature review from 2019 to 2024, we found that there were a lot of metabolites that were involved in the predicting the mortality and hospitalization in heart failure patients. So that helped us made this project basically where we summarize all the metabolites. In this poster, as you can see, we only mentioned like 5 of them because we were short of space and we had a restriction to the number. But in the entire article that we've made, the article is about 20 to 22 pages, and it is almost ready. And saying all of that, what I have learned from this poster is I'm going to focus on my health. I'm going to make sure that I ensure that I eat good foods. For example, TMAO is produced by the red meats. It is produced by the, so consuming more of red meat produces TMAO, and that has a negative effect on the heart failure, or it increases the chances of heart failure. And short chain fatty acids, depletion in them actually worsens the progression of heart failure. So this is some of the things that we've taken. We've also went into the management in the article, and saying all of this, Dr. Nadir, we're actually at the writer's block stage where our article is there, but we need a bit of polishing. We need a bit of diagrams and a bit of modifications in it. So I would like to use this opportunity to ask you or any of my fellow TGRF members, if they know anyone who can help us with getting this project done, because we are going to submit it to the Journal of Cardiac Failure, which has an index factor of about 6 or 8. So it's a really good journal. And for the 2025, they have waived the fees. It is usually about $1,500 to $3,000 for a full-length article. But for the year 2025, they have waived the fees, and it is actually a brainchild of HFSA. So because our abstract got accepted in HFSA, it is most sensible to make sure that we submit the entire article to the JCF journal. But at the same time, we are short of we are short of time. We just have 3 months. So, Dr. Nader, if you can guide on what should we do as the next step, and how to make sure that the article is ready, just pushing it. So if you have any advice, I'd be really grateful.
Yeah, so first of all, congratulations. That's great achievement. And when you're presenting this poster, that was awesome in this conference. As far as the article or submitting your manuscript to the journal, the good news, you have a journal and you have the manuscript, so it just needs the polishing. So for that, I have two things to recommend. One of them is, if there are similar articles in the journal regarding your topic, I would look at these articles and see how they wrote them. So you will have an idea of how to present the introduction and how to present, because you already have the data, the tables, other stuff. You already have them, the references. It's just the finishing. So if you look at previous accepted published articles with similar titles or related, and in the same journal, you will have a better picture to modify or improve your content. The other option is to use, I'm not sure if the journal will have any limitation of using AI in editing. So what I use is I go sentence by sentence and see what can the AI improve that sentence to make it clear for that specific journal or audience. Most likely you will target cardiology fellowships, and primary care, internal medicine, family medicine. These are your audience. So you want to make sure when you are writing your sentences they are very clear and give you the message that you want to show in the article. And when you look at the previous articles, you will have an idea about the background, how to put it in perspective. You list all previous major articles that you used maybe in your references, so that people will know where you're coming from, why this important, if that makes sense.
Yes, Dr. Nader, definitely. I'm going to make sure that I firstly may go line by line and see if I can edit. And then, of course, good suggestion to read the previous articles that were done. And also, Dr. Nader, I want to add, without your touch, nothing would have been done, neither the abstract, neither this poster. I remember it was so short of time and you always help. Thank you so much. Really appreciate it.
You're welcome. You did all the work, you and your team, so congratulations. This is great.
Thank you, Dr. Nader. And adding to that, I also wanted to update you that me and my fellow from TGRF, Roa Suleiman, we both submitted an abstract and updates in primary care conference, which is going to be held in Wheel Cornell Medicine, Qatar. And the topic is acral desquamation. It's a case report. It's a case that I'd seen in the clinic where I was doing my rotations. And I remember taking a picture, and once the opportunity arose, I took the permission of my attending, and he thankfully gave the approval, and we were able to submit this case report. The topic is acral desquamation following canned tuna ingestion, mimicking hand-foot-mouth disease in adults. So I just wanted to update you on that. Hopefully, we'll get a response in 2 weeks.
Excellent. This is also great, and we're looking forward to hear the good news. So,
Thank you, Dr.
yes, great work. Good job. Anybody else or anyone is working on some projects? Anyone working with Canva or any other AI tools to create mobile apps? Are you all applying for this year, or some will apply for next year residency, ERAS? So I ask because if you already applied and you are looking for the interviews, there are two things that I want to share with you. Number one, if you don't have presence in the social arena or area, I would like to advise you to do that. So I'm gonna share the screen. So for example, if you have LinkedIn account, please go ahead and advertise or sell yourself. For example, this guy, Ziad. So you just put a couple of sentences about you and your photo. Another person here also applying. So you mention whatever quality that you might have and put a photo. This will, some of the program directors or program faculty members might have an idea, and they can search you out and see if they can get more information about you and follow you, or you can follow them. Number two, in the app, if you go to the app, I added some videos. You go down here. One of them is this guy, Dr. Andrew. He is a program director, or he was, I'm not sure. But he gives some tips, and I added one of his videos. You can watch that. He has another like 11 or 12 videos. So beside him, we have different other videos that you can use to help you identify areas where you can like practice and improve your interview skills, and see what the program looks, what they are looking for when you are preparing, and how you do how you answer the questions, how to guide them to where you want to shine. So if they didn't ask you about certain things and you want to show them about that area, there are some tricks that you want to put in your answer. Usually you build your answer in a certain way that will show them that you understand the question, you want to discuss and elaborate on whatever aspect that you have, whatever skills that you will bring to the team there, because at the end of the day, they want someone who will join their program, will not cause problems, will get along well with seniors, and will take care of their patients, and will learn, and hopefully by the end of the whatever 3 years that you will spend, you will be able to be ready and pass the boarding exam, the board, whatever, family medicine, internal medicine, or any specialty that you go to. So these are the major quality that they want you to have, that you want to be a learner, dependable, you want to be self-disciplined, you can prepare for the exams, and also take care of the patients, and go along or get along well with your peers when you are junior, and next year when you are senior, for example, if that makes sense. Any questions? So I used AI Canva to build an app for you guys. I'm going to share it in the email with you. It's just a simple one to list some of the common questions, perhaps some of the techniques, some of the things that you may need during the virtual interviews or actual interviews. And hopefully this will help some of you. I'm sure most of you might have a good idea and now you are preparing. So the only thing you need is just practice, 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 and then hopefully you will get some interviews and you will shine there. Final things. Do you have any other ideas, questions, comments, any new thing about this program that you need us to focus on that will improve your life or other fellows? Well, if you do, please let us know. You can send me an email or call me. If you have questions, if you need any help, please let us know as well. We'll be happy to help you as much as we can. And I wish you all the best. And thank you so much, Dr. Mahasin and your team, for great presentations, and well done. Thank you everyone who joined today and attending this meeting, and those who will come and watch the recording in the future. Thank you in advance. Have a wonderful day, and we'll see you next week.
Thank you, Dr. Nader.
Thank you.